Good morning everyone. I am Dr. Vikas, Assistant Professor, Department of CT Surgery, Nizam Institute. My topic is on cannulation techniques and its nuances. Coming to the history, the first successful open heart procedure on a human using bypass machine was performed by John Gibbon on May 6, 1953 in Philadelphia. The operation was correction of an ESD on a 19-year-old girl. The basic bypass system is blood drained from the venous system utilizing gravity siphonage through cannulas placed in SVC, IVC or in RA into the blood drained into the venous reservoir. It is pumped into the membrane oxygenator and returned to the systemic via cannula placed in ascending aorta. Prior to the cannulation, the operative steps are a standard midline sternotomy was done, pericardial well is prepared, evaluation of heart is done, after which heparin is given. After 3 minutes, ACT was checked, then purstring sutures are taken with 20 Prolene sutures on aorta, 40 Prolene suture purstring taken on SVC and 30 over IVC. After ACT more than 480 seconds, serial cannulation was done. Here the picture showing the cannulation sites of arterial and venous. Ascending aorta cannulation done at the pericardial deflection just below the innominate artery. SVC cannulation done just above the SA node and at the pericardial deflection. IVC cannulation was done at the 1 centimeter above the IVC RA junction, and RA appendage cannulation and free wall of RA cannulation was also done. Coming to aortic cannulation can be central or peripheral cannulation. Arterial cannulation can be central or peripheral cannulation. Here the picture shows central cannulation like aorta, peripheral cannulation axillary artery, subclavian artery, innominate artery, femoral and iliac arteries. Site selection for arterial cannulation. As most commonly we are doing ascending aorta cannulation, distal ascending aorta, anterolateral surface or inner curve of the ascending aorta just proximal to the takeoff of innominate artery was the site for aortic cannulation, and we should leave adequate space for the aortic cross clamps, cardioplegia cannula and potential proximal anastomosis. Pre-cannulation assessment was done through palpation or through TE. The purstring, two concentric purstring sutures with the 20 Prolene taken over the ascending aorta. The sutures are placed through adventitia and media. The first purstring is often placed using a forehand and backhand pattern, creating a square or diamond configuration. And the second suture is placed concentrically mirroring the first suture. The first suture is external and of the aortic wall. The second passes, first will be internal and second will be the external and vice versa, which maximizes the sealing effect at the time of decannulation. After taking the purstring suture and achieving the ACT, the clearing the adventitia over ascending aorta within the purstring sutures, which helps us in cleaner incision and smoother cannulation. Incision is done with 11 number blade, full thickness, appropriate size, and transverse orientation is done. Finger over the opening or approximating the adventitia with forceps are most commonly done before inserting the cannula. Care must be taken to avoid the deep penetration of the scalpel, which could injure the posterior aortic wall, particularly if systemic blood pressure is low. Hemodynamic control at the time of cannulation should be less than 100 to 110 mm of mercury during insertion. At the time of insertion, the cannula is inserted smoothly into the lumen. The aorta can be stabilized with forceps or retracted through the right angle to aid for the insertion. Resistance should not be forced. The cannula tip should be project only a short distance of 5 to 10 mm into the lumen and be directed distally towards the aortic arch, avoiding inadvertent cannulation of the innominate artery or arch vessels. Confirmation of the cannulation, retrograde filling of the cannula with the pulsatile blood flow is seen in the cannula, and check the line pressure and for excessive resistance. Using snares or tourniquets, snares are positioned below and side ports of the cannula. The snares are secured together with a heavy tie, and the cannula may be further secured with a suture to the skin or drapes. Before connecting, the cannula is allowed to fill with blood retrogradely, helps in de-airing of the cannula. The arterial line is then connected under fluid while the perfusion slowly advances the prime fluid retrograde through the line to expel the remaining air. Complications of aortic cannulation: bleeding, aortic dissection, embolism, malposition of the cannula, posterior wall injury, cannula disruption and dislodgement of the cannula. Here the cannula was aortic cannula was too much inside and perfusing one of the arch vessels, and in the image B, the cannula was misdirected and perfusing only the first branch of arch. Only 3 to 5 mm cannula was inside in the image C. If the cannula was too small to the aorta, then it causes a jet effect. Coming to venous cannulation, basic principles of venous cannulation is through gravity siphonage. The patient and CBB head should be 40 to 70 distance, and the vacuum assisted venous drainage through. Venous drainage is affected by intravascular volume and venous compliance, sympathetic tone, and venous shattering and blood drain. Here the image shows types of venous cannulation: bicaval cannulation and cavo-arterial cannulation. Venous cannula were made up of flexible plastic wire reinforcement cannulas. The tips might be straight or angled or rigid or plastic metal. The appropriate cannula depending upon the patient size and anticipated flow rates, index catheter indices. For an average adult, 30 French SVC plus 34 French IVC cannulas was used. In a cavo-arterial cannulation, single 42 French cannulation was used. Insertion through purse string at right arterial appendage or RA free wall, SVC or AVC. Coming to single cavo-arterial cannulation, also called as two-stage cannulation, a single large bore cannula with multiple stages is inserted typically through the RA appendage or RA free wall. The distal tip is advanced into the inferior vena cava near to the hepatic vein, which more proximal side holes drain blood from the RA and superior vena cava. Technique: a single full thickness purse string suture is placed on the chosen RA site like appendage, which is easy for the closure after decannulation, on the RA free wall, which is easier for insertion of the cannula. And arteriotomy done after purse strings with the 11 mm blade or scissors and gently dilated with the dilator. Cannula is inserted and directed inferiorly towards the IVC, guided by external feeler markers of the cannula, and the purse strings is snared around the cannula and secured. Careful placement of the purse string bites is essential to avoid tearing the fragile RA wall, and the suture should avoid within the AV groove because of the risk of RCA injury, and at the SVC RA junction because of the risk of SA nodal injury. Coming to bicaval cannulation, SVC and IVC cannulation, procedure requiring right bicaval cannulation is done in the procedures which requiring right arteriotomy like tricuspid valve surgeries, ASD, VSD repairs, and for optimal exposure during mitral valve surgery. A separate purse string sutures full thickness are placed directly on the SVC and IVC, SVC and IVC, and venotomy incision was done with 11 mm blade and dilated with the dilator. Cannulas are secured with the snares. Umbilical tapes are typically passed around the SVC and IVC and tightened around the cannula after CPB initiation to ensure complete diversion and prevent air entry when the right heart is open. And the care must be taken when exposing the SVC requires careful dissection of the pericardial reflection. Sharp dissection is preferred over cautery to avoid thermal injury to the nearby phrenic nerve. Care must be taken not to entrap central lines within the SVC purse string. The IVC wall can be particularly fragile and prone for tearing. Complications of venous cannulation: poor venous drainage, airlock, atrial or caval tear, malposition of the cannula, injury to the adjacent structures, and venous shattering. Causes for the low venous return: because of hydrostatic gradient, inadequate right heart venous reservoir, venous pressure, low CVP, cannula position and size, circuit obstruction, excessive resistancy of the cannula, right-sided pressures, and surgical manipulation of the heart. Coming to peripheral cannulation, femoral artery cannulation. Historically, it was standard cannulation previously. Now we are doing in only selective cases. Still vital for minimal invasive surgeries, reduced sternotomies, and emergencies. Pre-cannulation assessments were done by palpate the femoral pulses, pre-op CT angio, ultrasound to assess the vessel quality, and to identify the common femoral artery and branches. Cannulation technique: A vertical or oblique incision given below inguinal ligament and pursing taken over the common femoral artery, and direct incision of the femoral artery, and the cannula was placed, and straight cannula was placed into the femoral artery. Care must be taken to lymphatic control, critical to avoid lymphocele, and percutaneous Seldinger technique was also done. Care be taken while gentle handling of the cannula while inserting the cannula, and confirm the tip with TE. If resistancy was there while inserting the cannula, and extend the femoral arteriotomy. Complications like retrograde aortic dissection, limb ischemia and compartment syndrome, embolism and stroke, vessel injury, local site complications, pseudoaneurysm formation, retroperitoneal hemorrhage, and dilation, tortuosity and post decannulation bleeding was common complications seen with femoral artery cannulation. Another peripheral cannulation was axillary or subclavian cannulation, popular for complex aortic surgeries, reduced sternotomies and minimal invasive surgeries, which provides antegrade flow, reducing embolic stroke risk, enables selective antegrade cerebral perfusion. Indicated in type A aortic dissection repair, Prosylene aorta, ascending and arch aneurysm repairs, reduced sternotomies, and minimal invasive surgeries. Precannulation assessment, bilateral radial pressures to rule out subclavian stenosis, CT angioimaging to assess vessel size, disease and tortuosity. Cannulation technique can be done in direct cannulation or side graft technique. Infraclavicular incision is given and the deltopectoral glove is dissected. Vessel was looped in for the control of the vessel, and single pursing suture was taken, and stab incision was given, and 16 to 20 French cannula was inserted for less than 3 centimeters, and post decannulation repair was done by patch angioplasty or direct closure. In the side graft technique, 8 to 10 mm diaphragm graft, end to side anastomosis was done to the axillary artery. Cannula is inserted into the graft, and graft stump over soon after CPB. Careful dissection is done for the axillary artery to avoid brachial plexus injury. Artery lies posterior and superior to the axillary vein, and limit cannula depth to less than 3 cm to avoid carotid and vertebral artery occlusion. Complications include the brachial plexus injury, axillary artery injury and dissection, limb ischemia, can have flow issues, local site complication, neurological complication, and inadequate flow or vessel trauma. Other peripheral arterial sites like innominate artery, carotid artery, and transapical aortic cannulation was done. Thank you.
Any questions, sir?
We'll take the questions at the end of the session.
Thank you, Dr. Vikas, sir.